let's move on to the thyroid gland diseases, which I'm going to start from today's class, and I still need a few more classes to finish it. So let's enter into the topic. Now, in the beginning, let's talk about thyroid hormone and what are the important functions of this. The thyroid gland synthesizes two hormones, that is L-thyroxine, are also known as tetraiodothyronine or T4 and triiodothyronine, which is T3, of which T3 acts at the cellular level and T4 is the prohormone. Prohormone means inactive form of the hormone. When it reaches at the tissue level, see that this T4 will be converted into T3 and this T3 will act at the cellular level. Now, where is the receptor of thyroid hormone? Where it is located?
Nuclear receptor.
Nuclear.
Nuclear.
Nucleus, inside the nucleus.
Very good. Intranuclear receptor or inside the nucleus. Excellent answer. So it acts there and shows its effect. Now, inorganic iodide is trapped by the thyroid gland, especially the follicular cells. It is oxidized and incorporated into the glycoprotein, which is known as thyroglobulin, to form mono and diiodotyrosine. And later on, this is converted into T4 and T3. So this is the mechanism of synthesis of hormone. So we need iodide or iodine in the synthesis of thyroid hormone. Very, very important one. Okay. And in the process, thyroglobulin is necessary. Ultimately, mono and diiodotyrosine is formed. And when, one molecule of monoiodotyrosine and one molecule of diiodotyrosines are combined together, then T3 is formed. Because one iodine comes from here and two iodine comes from here, okay? Like that, T3 is formed. And similarly, when two diiodotyrosine fuses with each other, we call it, okay, tetraiodothyronine. So these are some of the important points. Okay, so let's move on. Now, let's talk something more about thyroid hormone. More T4 is synthesized by thyroid gland. There's no doubt about it. T4 is an overwhelming, in overwhelming concentration than T3. But this T4 is converted in peripheral tissues to T3, like liver, kidney, and muscle. Then T3 will act there. The process is known as 5-mono-deiodination because one molecule of iodine is removed from there. 5-mono-deiodination. In plasma, more than 99% of all T4 and whatever T3 is there, it will bind with their carrier protein. These are known as hormone binding proteins. There are different names there. Okay, so let me underline this name. These are known as thyroxine binding globulin or TBG, thyroid binding prealbumin, TBPA, or albumin itself. So these are called as carrier protein or hormone binding protein in relation with T4 and T3. Only free hormone is available for tissue action. Remember this, where T3 binds to a specific nuclear receptor within the cell and it shows its effect. Now, when we order thyroid function test, okay, they give us the report of only free hormone because we are only concerned about that free hormone. We are not concerned about the total hormone there. Let's move on. Now, with this, a bit of physiological discussion, let's talk about what are the physiological effects of thyroid hormone, or in other words, what are the functions of thyroid hormone. Regarding the cardiovascular system, see here, regarding the cardiovascular system, it increases heart rate and cardiac output. Very easy to remember. Now, why? In case of hyperthyroidism or thyrotoxicosis, there is palpitation, there is tachycardia, and there is increased cardiac output, which is known as hyperdynamic circulation. So this is the way you remember what is the function of thyroid hormone in the heart. Regarding the bone or skeletal system, it increases bone turnover and resorption. So in case of hyperthyroidism, the bone may become weaker. Regarding the respiratory system, it maintains normal hypoxic and hypercapnic drive in the respiratory center. What does that mean? It makes respiratory center quite alert, okay, or responsive. Respiratory center is stimulated by either hypoxia or hypercapnia. These are the two important drive there. So thyroid hormone helps to maintain that drive. Regarding GI, it increases gut motility. That's why in case of hyperthyroid condition, the person may develop diarrhea, okay, or crampy type of abdominal pain. Whereas in hypothyroidism, the person develops constipation because the gut motility is reduced. Okay. In the blood, there is increased 2,3-DPG inside the red blood cell. Okay, increase 2,3-DPG. This 2,3-DPG or 2,3-diphosphoglycerate facilitate the oxygen release to the tissue. This is also known as unloading of the oxygen to the tissue. What is the function of hemoglobin? We all know. It will bind with the oxygen first. It will transport oxygen in the blood. And when it reaches the tissue, remember, it should give that oxygen easily to the tissue. This is known as unloading. So 2,3-DPG helps to unload it. And thyroid hormone helps in the excessive synthesis of 2,3-DPG inside RBC. So this is also important function. And regarding the neuromuscular, it increases the speed of muscle contraction and relaxation, as well as increases the muscle protein turnover. So let me elaborate on this now. In case of hypothyroidism, one of the very important clinical feature we examine in our patient is, okay, the tendon jerk, especially the ankle jerk we elicit in front of us. And just closely watch the muscles which are contracted during ankle jerk. Now, can I ask you which are those muscles which I look during ankle jerk? Which are the muscles?
Calf muscles.
Exactly, they are calf muscle, right? So if I want to take the name of those muscles, then they are gastrocnemius and soleus, or calf muscle. Just focus there. There is very slow relaxation during hypothyroidism of those muscles. This is utilized as one of the important clinical feature of hypothyroid patient. Now let's come to hyperthyroidism. Hyperthyroidism patient, okay, they are anxious, they are irritable, okay, the sympathetic nervous system is overactive in them, so the tendon reflexes are also hyperactive. This is one point. Another, the muscles also become weaker and slightly thinner in case of hyperthyroid case. Okay. Now let's continue. We're talking about the physiological effect of thyroid hormones in different body organs and tissues. Now, what is the function of thyroid hormone in relation to carbohydrate metabolism? This is also important point to understand. Thyroid hormones increases hepatic gluconeogenesis, glycogenolysis, and intestinal glucose absorption. So all these mechanism will cause what regarding the glucose level? So what happens to the blood sugar level? Yes,
Hyperglycemia.
Increase.
exactly. All of these will lead to increased blood sugar level. There's no doubt about it. Because gluconeogenesis is new glucose formation or synthesis. New glucose formation or synthesis. So it will lead to excessive glucose level in the blood. Glycogenolysis is the breakdown of glycogen into glucose, and increased intestinal absorption will also do the same thing. Now, what happens to the protein, okay, or the lipid metabolism? Protein metabolism, we already talked about. They break down some of the proteins from the muscle. So especially in case of hyperthyroidism, the muscle become a bit weaker. But regarding the lipid, it increases lipolysis, which leads to free fatty acid in plasma and increased fatty acid oxidation in different tissue. Okay, so increased lipolysis leading to free fatty acid in plasma and increased oxidation in different tissue. That's why hyperthyroid cases and hypothyroid cases will present in a bit different way, exactly opposite way of each other. Hypothyroid case usually presents with hyperlipidemia, okay, hyperlipidemia, whereas hyperthyroidism usually presents with hypolipidemia. So this is the way you remember. In case of sympathetic nervous system or sympathetic nervous tissue, thyroid hormone increases catecholamine sensitivity and beta adrenergic receptor number. That's why it causes tachycardia, it causes palpitation, okay, and all those problems. So these are very, very important function you should never forget. Now, before I enter into other aspects of the thyroid gland disorders, okay, let's focus ourselves on thyroid function test. So I want every student to pay attention here because this is a very, very important knowledge. Though I already talked about this in the beginning of the class. See here. The first is thyrotoxicosis. Now, what happens in thyrotoxicosis if I do thyroid function test? Thyrotoxicosis can be of two types, primary and secondary. Now, see here, the most important point in thyrotoxicosis is the T4 and T3 level. So they must be increased. Without increased level of T4 and T3, I cannot call it thyrotoxicosis. So these are always seen in the beginning. Now, to differentiate whether it is primary or secondary thyrotoxicosis, I look at TSH now. If TSH is suppressed, okay, if TSH is suppressed or if TSH is very low, then this is primary thyrotoxicosis. That means the disorder is in the thyroid gland itself. Whereas if TSH is also high along with T4 and T3, then this is central or secondary thyrotoxicosis. The major problem here is excessive TSH secretion, which in turn will cause increased T4 and T3 release. So this is very easy to understand. Now, similarly, primary hypothyroidism. Now see this. The main thing which I see here is T4 and T3 again, and they should be low. They should be low. Okay. In early cases, they may be low normal or even normal. So T3, remember T3 is the active component of the hormone. In many of the cases, T3 level is still normal, but T4 is already low. So these all are important practical tips for you. And what about the TSH now? It should increase because I'm talking about primary hypothyroidism. Because of negative feedback mechanism, this TSH should be increased. But in case of secondary hypothyroidism, where the disease starts from hypothalamus or anterior pituitary, the TSH is always low first, and then the T4 and T3 are also low. Okay, now see that this condition is written here, TSH deficiency. I am explaining this as a central hypothyroidism, but it is mentioned here as a TSH deficiency. So it is low normal or subnormal or low already, and everything is low after that. See it. There is a condition known as T3 toxicosis, where only T3 is excess. See here, T3 is excessive, T4 is normal here, and because of the negative feedback of this T3 on hypothalamus and anterior pituitary, TSH hormone is low. This is suppressed. There is a condition known as compensated euthyroidism. Euthyroidism is normal thyroid hormone level. Okay, this is compensated mechanism. So here T4 is normal, T3 is also normal, but TSH is slightly increased. Okay, this is also known as subclinical hypothyroidism. Subclinical hypothyroidism. Now, why I am calling it subclinical? Because there are no signs and symptoms. T4 and T3 are normal, but TSH is increased. So why TSH is increased? Probably this is early cases of hypothyroidism. Till now, there are no signs and symptoms, but later on, signs and symptoms may arise. After knowing this important, slide, let's move further and talk about some of the problems in interpretation of thyroid function test. Okay, they may alter how we interpret the thyroid function test. One of that is serious acute or chronic illness. In serious acute or chronic illness, there is reduced concentration and affinity of the binding proteins because there is deficiency of protein in this situation, and this thyroid binding globulin, albumin, these all are different types of protein. So their level is low. Now what will happen? There is decreased peripheral conversion of T4 to T3 with more, reverse T3. This R is for reverse T3, means this doesn't have any physiological function. This is a useless, a type of T3. So it doesn't have any clinical significance. So that exactly happens in case of serious acute or chronic illness. And there is reduced hypothalamic pituitary TSH production. Okay, so these are the features. In pregnancy, okay, what is the problem in interpretation now? Pregnancy lead to greatly increased thyroid binding globulin level, and it leads to high normal total T4, but free T4 is usually normal. So if you order thyroid function test where they are measuring the total hormone, then your interpretation should be slightly different now. But if you have ordered free T4 and T3, it doesn't matter. Okay, so this is small information. And then what is the effect of the drugs? Okay, some of the drug, they can affect the thyroid hormone level. So what are those? So let me underline this because this is an important question in the exam. Amiodarone is a drug which decreases T4 to T3 conversion, and free T4 levels may therefore be above the normal in a euthyroid patient. So what does that mean? The active component called T3 will be less, and T4 is a bit high in the presence of amiodarone. Now, which type of drug is amiodarone? Where we use this drug?
Anti-arrhythmic.
Very good. It is anti-arrhythmic drug. Okay, it is known as class 3 anti-arrhythmic drug, and this is iodine containing drug. Okay, iodine containing drug. Now remember, thyroid gland uptake iodine very actively. Wherever iodine is present, thyroid gland will uptake that iodine. So amiodarone is also actively taken up by the thyroid gland, and it can damage our thyroid gland. Okay, so this is a very important example of the drug which has effect against the thyroid gland. This is the take-home messages from this slide for you. So amiodarone, okay, may induce both hyper and hypothyroidism. The TSH level is usually reliable in the diagnosis of hyper and hypothyroidism in this case. Now you may be wondering why the same drug may be causing hypo and hyperthyroidism. Hyperthyroidism may be caused by excessive iodine content of amiodarone, and hypothyroidism may be explained by decreasing the conversion of T4 to T3. So this is the way you give explanation here. Many other drugs affect the thyroid function test by interfering with protein binding, but this now rarely causes a problem with free T4 assay. Okay, so we ignore this thing these days because we are ordering the free T4 level. Now we are almost towards the end of the class. Before I enter into the topic proper, let's talk a little bit about anti-thyroid antibody. This is a very important concept, okay? So I want every student to pay attention here. There are many conditions, okay, which damages our thyroid gland. Now, what I'm talking here is the autoimmune diseases. Like Graves' disease is a type of autoimmune disease. Hashimoto's thyroiditis is also a type of autoimmune disease, okay? But the type of antibody which may be present in those conditions are a bit different. Sometimes, okay, similar type of antibodies may be found in both conditions also. Okay, so with this, let's enter into this slide. Serum antibody to the thyroid glands are common. It's quite common, and it may be either destructive or stimulating type. Both occasionally coexist in the same patient. That's what I was talking right now. Now, don't be surprised if you find, inhibitory antibody in Graves' disease patient and stimulatory antibody in Hashimoto's thyroiditis patient. But they are completely different condition. Graves' disease is all about hyperthyroidism, whereas Hashimoto's thyroiditis mainly present with hypothyroidism. That's the meaning. Destructive antibodies are directed against the microsome or against the thyroglobulin of the thyroid gland. So when they are directed against these things, they leads to decreased production of thyroid hormone. The one small example given here is thyroid peroxidase enzyme, also known as TPO enzyme. This enzyme is very, very important in the synthesis of thyroid hormone. If there are antibody against this enzyme, then thyroid hormone cannot be synthesized properly, leading to hypothyroid state. Okay, and this is one of the main mechanism in Hashimoto's thyroiditis. Now let's talk about the opposite of the effect here. Sometimes the antibodies are stimulatory type, and a good example here is TSH receptor IgG antibody. Okay, TSH receptor IgG antibody. It typically stimulates the thyroid gland, but occasionally it may block the receptor as well. But more commonly, it will stimulate the thyroid gland. Now, just think about the process. When thyroid gland is stimulated, what happens? There is excessive secretion or synthesis of T4 and T3, and by doing that, it will commonly cause hyperthyroidism or thyrotoxicosis. Okay, thyrotoxicosis. Sometimes some of the antibodies are there which will block the TSH binding receptor. So if they block the TSH binding receptor, then the hypothyroidism will occur. Okay, hyperthyroidism will occur. Now, don't get confused. So let me make it very clear for you at this moment. If I am doing investigation in case of Graves' disease is an excellent example of thyrotoxicosis or hyperthyroid condition. I may also get blocking autoantibody there. But the effect of that blocking antibody is far lesser than stimulating antibody. Whereas when I am investigating a case of Hashimoto's thyroiditis, okay, the anti-peroxidase, antibody or thyroid peroxidase, we call it anti-TPO antibody, is the most dominant there. But don't be surprised if you get the stimulatory antibody also there in the patient. So this is the meaning of or antibody against the thyroid gland. Okay, so we still have a bit of time. I will repeat this in my next class also. But before we finish this class, let's quickly classify the thyroid disease. We divide this into hormone excess, hormone deficiency, and non-functioning tumor. Now see there, the hormone excess condition are primary and secondary. Primary are Graves' disease, multinodular goiter, thyroid adenoma, this is a tumor, and subacute thyroiditis is a infection or inflammation occurring in the thyroid gland. Whereas secondary is pituitary TSHoma, means a tumor which is developed from thyrotrop cell in the anterior pituitary. Hormone deficiency conditions are primary and secondary again. Primary is Hashimoto's thyroiditis, secondary is hypopituitarism, when pituitary gland is not functioning well. And then some of the non-functioning tumors also occur in the thyroid gland. They are differentiated carcinoma, okay, medullary carcinoma, and lymphoma. Among these carcinoma, papillary carcinoma of thyroid, follicular carcinoma of thyroid are very common.
Anything. Let's move on. Now let's talk about hyperthyroidism. This is a very important class from the exam point of view. Not only from the exam point of view, when you start working as a doctor, a lot of hyperthyroid case will come to you, even as a general physician. So let's focus on the class. Hyperthyroidism, also known as thyrotoxicosis, very commonly used term, or thyroid overactivity. Thyroid overactivity is quite common, affecting perhaps 2 to 5% of all female at some time of their life. So it is more common in female than in the male. And the reason is autoimmune thyroid disease. Okay, because of that condition, it is more common in female. That is Graves' disease. Graves' disease is one of the most important cause of hyperthyroidism. That's why it is more common in female. Now see this, sex ratio of female to male is 5:1. So it is 5 times more common in female than in male. And the age group is between 20 to 40 years. Nearly all cases, almost more than 99%, are caused by intrinsic thyroid disease. Okay, that is primary hyperthyroidism. A pituitary cause is extremely rare. It is less than 1%. That means secondary hyperthyroidism or central hyperthyroidism is quite rare condition, but sometimes even that rare case may come to you. So we should have a knowledge. We should know how to diagnose it. Let's move on. Okay. Now look at the causes of thyrotoxicosis. Okay, please pay attention here. These are the common causes. Graves' disease. This is autoimmune disease of the thyroid gland. Multinodular goiter. Thyroid gland is enlarged with multiple nodularity. It is quite a hard type of feeling there. It is hugely enlarged, and very asymmetrical type of nodules are there. Some nodules are quite big, some are smaller. So asymmetrical enlargement. Third is autonomously functioning solitary thyroid nodule. Solitary thyroid nodule. Just one nodule is there, and that nodule is hyperfunctioning. Can also call it thyroid adenoma. Thyroiditis is the inflammation of the thyroid gland, and the common cause is de Quervain thyroiditis. Try to remember this name, de Quervain. Okay, this de Quervain thyroiditis is also known as subacute thyroiditis, usually caused by viruses. We'll talk about this. Another is postpartum, after the childbirth. Now, some of the drugs which can lead to hyperthyroidism is amiodarone. Never forget this. In the last class also we talked about this. This is actually antiarrhythmic drug, okay, class 3. It is iodine containing drug. That's why it produces its side effect regarding the thyroid gland. Let's move on. There are some other causes as well. See here, sometimes thyroid hormone comes from other sources, that is outside the thyroid gland, and that is factitious hyperthyroidism and struma overi. Now, let me ask you this question. What do you mean by factitious hyperthyroidism? Anybody? What do you mean by this term?
Sir, this is common in psychiatric patient-induced hyperthyroidism.
Very good. Good. Okay. Now remember, this term is quite common in different clinical conditions. Even in diabetes, sometimes the patient inject themselves as insulin, or even if they are normal, if they are not a diabetic patient, but still they inject insulin and presents to the hospital with severe hypoglycemia. So these cases are known as factitious. Okay. Now see this factitious hyperthyroidism. They are probably taking too much thyroxine hormone and present to the hospital with the features of hyperthyroidism. Sometimes it is quite challenging for us to diagnose them. So we admit them in the hospital, okay, and then strict monitoring is done. Probably CCTV camera would be excellent idea here, and we'll see they are taking those thyroxine drug on their own and presenting the symptom. Another is struma overi. Now this is ovarian tumor which is secreting thyroid hormone. Now remember, there are different types of ovarian tumor we have studied. One type is called teratoma, and that teratoma can have different cells or tissues inside it. They are derivative from ectoderm, endoderm, and mesoderm. Everything is there. So this thyroid gland is the derivative of endoderm. So as a result of this, even thyroid hormone secreting cells may be present there. If they secrete thyroid hormone and causes hyperthyroidism, we call that struma overi. So it can be an important MCQ question in the exam. Struma overi. Let's move on. Now see that. Another is a TSH induced. Now TSH is thyroid stimulating hormone which is released by anterior pituitary. So in which case it is produced there, or it is excessively secreted. One is adenoma, or the tumor in the pituitary gland. This is known as TSH secreting adenoma or TSH-oma. We already talked about it. Another is not in the pituitary gland. It may be outside the pituitary gland, like choriocarcinoma and hydatidiform mole. Now, let me say a little bit about them. Okay, these are quite interesting conditions. Okay, and you should exactly know how they lead to hyperthyroidism. Now, just answer one thing to me. Which hormone is released by them? Choriocarcinoma and hydatidiform mole. Which hormone?
Beta HCG, beta HCG.
Exactly. Very good. It is beta HCG. Excellent. You can simply say HCG. That answer is also correct. What is the full form of HCG? HCG means what?
Human chorionic gonadotropin hormone.
Excellent. Human chorionic gonadotropin hormone. This human chorionic gonadotropin hormone, just like most of the other hormone, has got two components, alpha and beta. Now, this beta component, okay, of this HCG hormone has got action, okay, just like TSH. It has action a bit like TSH. That is the reason why this choriocarcinoma and hydatidiform mole can also lead to hyperthyroidism. Just remember that much. Now, this choriocarcinoma is the malignant tumor which is derived from the placental tissue. and high dietary from mole is also known as molar pregnancy. I'm sure you have already studied them in obstetrics and gynecology. Now let's move on. Another is follicular carcinoma with or without metastasis. Now, follicular carcinoma can secrete or produce thyroid hormone, and especially if they are metastasized to the different parts of the body, then the amount of thyroid hormone is much more. Okay, so this may be one of the cause. Now to summarize, what are the causes of thyrotoxicosis? You should never forget the four important causes. Number one, Graves' disease. Number two, multinodular goiter. Number three, toxic adenoma, okay, or solitary nodule in the thyroid gland, isn't it? And then some other drugs, any other thing you can add there, like drugs, okay. Some secondary causes, struma ovary, factitious hyperthyroidism, and follicular carcinoma. Let's move on. Now with this information, let's talk about Graves' disease. Now Graves' disease is the most common cause of hyperthyroidism in the patient, and this is autoimmune process. So you can also call it as autoimmune disease, which is damaging the thyroid gland. Now, what is really happening here? See here, in this condition, the serum IgG antibody are formed. These IgG antibody are stimulatory type of antibody. So they bind to TSH receptor in the thyroid gland. Okay, the receptors which are present in the thyroid gland where TSH hormone binds and stimulate them. Now, in the place of this TSH hormone, this antibody will bind to that receptor, and they are a stimulatory type of hormone. So they stimulate the thyroid gland to synthesize more thyroid hormone. Okay, so this is the main pathogenesis here. In other words, they behave like TSH itself. So they behave like TSH hormone. So they have got different name because of these functions, you know. So these TSH receptor antibody, we call them TSH receptor antibody, or TSI, thyroid stimulating immunoglobulin also. We also call them TSI, thyroid stimulating immunoglobulin. So these two terms are quite commonly used in the clinical practice. Thyroid, TSH receptor antibodies, like here, TSH receptor antibodies or TSI. Don't get confused. Now, let's talk something more about them. Okay. Now see that. So it can be measured in serum and are present in almost 85 to 90% of the cases, and they decline with the treatment. So we need to show them for the confirmation of our diagnosis. We need to prove them, yes, they are present in the serum, and they are present in almost 85 to 90% of the cases. And another thing, after we treat Graves' disease, the level of these autoantibodies also decline. So this is a good thing. Graves' disease is associated with HLA-B8, DR2, okay, and DR3. So this is a genetic association of Graves' disease. HLA-B8, DR2, and DR3. So these genes are associated. Graves' disease, being an autoimmune disease, is also associated with other autoimmune disorder in the body. Very, very important point, like pernicious anemia, like vitiligo, okay, myasthenia gravis, type 1 diabetes, Addison's disease, okay. So some other examples. Now, what is pernicious anemia?
Deficiency of vitamin B12.
Vitamin B12 deficiency due to
Autoimmune
autoantibodies
diseases which
against the
lead to
thyroid cells.
vitamin B12 deficiency.
Metabolic anemia.
Very good. So many students are actively answering it because they know the point here. So pernicious anemia is, okay, a type of megaloblastic anemia where intrinsic factor is deficient. Understand like this. Intrinsic factor is deficient, which leads to megaloblastic anemia, that is known as pernicious anemia. So we need to know a little bit more here. Intrinsic factors are released by which cells? Which cell releases intrinsic factor?
Parietal cells of
Parietal cells of the stomach.
Parietal cells of stomach. Exactly, parietal cells of the stomach. So in this condition, they are damaged by, okay, autoimmune process. That means some autoantibodies are also present there, which are known as antiparietal cell antibody, okay, that will attack those parietal cells. They are damaged. There is no release of intrinsic factor, and we need intrinsic factor for the absorption of vitamin B12, and that is known as megaloblastic anemia, and the overall picture is called pernicious anemia. So pernicious anemia is considered as an autoimmune disease. Now vitiligo is the skin, manifestation. It affects the skin and even mucous membrane sometimes. So this is a very white, patch present on the skin. In other words, the melanocytes are destroyed. So there is no melanin production in case of vitiligo. Okay, this is called marker of autoimmune disease. Always remember this point. So if somebody presents with vitiligo, then as a doctor, I need to think maybe this patient is having some other autoimmune disease inside the body. So I need to take some good history. But don't worry about the investigation for the time being. If the patient gives certain symptom and sign, then only go for those investigation. Okay, so that's the way. And we have talked about myasthenia gravis already. Now, the signs and symptoms of Graves' disease will be talked a little bit later. Okay, so what is de Quervain's thyroiditis? What do you mean by this? Let's talk about it now. This is another cause of hyperthyroidism. So here, this is transient or transitory hyperthyroidism from an acute inflammatory process of the thyroid gland, and most probably it is viral in origin. So these viruses, they attack the thyroid gland, they cause infection or inflammation there, and probably some hormone which is stored there inside those thyroid follicles, those hormones will be released after the inflammatory process, and that's why it leads to hyperthyroidism. Just remember like this, I'm making it very simple. So whenever there is inflammation going on there, the hormones, if they are already stored in that particular area, they will be released because there is a capillary permeability increase and all sort of things. So this is the cause of hyperthyroidism. But later on, if the damage is excessive, even hypothyroidism may occur. So in the early phases only, there is hyperthyroidism in this case. Now let's talk something else. Apart from the toxicosis means hyperthyroid condition, there is fever, malaise, and pain in the neck with tachycardia and local thyroid tenderness. So you can easily remember them because there is infection going on. Because of infection, there is fever. There is pain in the neck. Okay, because of the viral illness, malaise is very common. Because of the same infection, tachycardia is common, and tachycardia is again explained by hyperthyroid state, and local thyroid tenderness is a very common feature. Now if we do thyroid function test or TFT, it shows initial hyperthyroidism. That's why I am explaining right now. But later on, okay, later on hypothyroidism may occur if the thyroid gland is badly damaged. Never forget this sentence. ESR is raised because of infection. Thyroid uptake scans show suppression of uptake in the acute phase because of the destruction. Hypothyroidism usually transient, may then follow after a few weeks. Okay. The amount of damage done by this de Quervain thyroiditis is not massive, so even hypothyroidism is a bit transient. Now, treatment of the acute phase is with aspirin, that is NSAID, and we can go for short-term prednisolone in severely symptomatic cases. Because this is a viral in nature, it will recover after some time. Now, another is a drug-induced thyrotoxicosis, and one of the drugs which is very commonly implicated here, is amiodarone. Okay, amiodarone. So let's talk a little bit about that drug, how it causes hyperthyroidism. So amiodarone is a class 3 antiarrhythmic drug. You all know that. It causes two types of hyperthyroidism. Now what are these? These are called type 1, okay, and type 2. Now see there. Type 1 amiodarone induced thyrotoxicosis and type 2 amiodarone induced thyrotoxicosis. The mechanism is a bit different here. So type 1 amiodarone induced thyrotoxicosis is associated with pre-existing Graves' disease or multinodular goiter. The patient is already having this problem there. On top of that, if they take amiodarone, then because of the high iodine content of amiodarone, more thyroid hormone is synthesized and released, which is the result which causes thyrotoxicosis. So it is simply because of high iodine content of the amiodarone, and the patient should have some pre-existing disease there. This is type 1. And whereas type 2 amiodarone induced thyrotoxicosis is not associated with previous thyroid disorder and is thought to be due to direct effect of the drug on thyroid follicular cells, leading to destructive thyroiditis. It is a bit similar to decoy vein thyroiditis, which we just studied. In that condition also, the viruses, they attack the thyroid gland and cause inflammation. So similarly, this drug is also causing destruction of the thyroid gland with release of preformed T4 and T3. So this is also causing transient type of hyperthyroidism. Okay. Now, one more function of amiodarone also exists. It inhibits the deiodination of T4 to T3 in the peripheral tissue. So it is associated with higher T4 than T3 ratio than usual patient. So just remember this. This is blocking the deiodination, means it doesn't allow the conversion of T3 from T4. So the peripheral action of T3 may be hampered. And one more point I like to add here, it can also cause hypothyroidism, and the mechanism is similar to the dequervant thyroiditis. Remember, there also in the late stage hypothyroidism can occur. So here also hypothyroidism can occur, a similar type of mechanism. Okay, so let's move on. Now, with this discussion, let's enter into the very important part of today's lecture, and that is clinical feature. Now, all of the students should know in detail about the clinical features of hyperthyroidism. Okay, so this is taken from a textbook. So let me explain some of the important points here. These are the symptoms on this side, and on the other side there are the signs. So let's start with the symptoms. Weight loss, a very important symptom of hyperthyroidism, because hyperthyroidism is hypermetabolic state. Okay, the patient burns more calorie in hyperthyroid condition. That's why there is weight loss. Another thing, the patient may develop diarrhea. Okay, and when they develop diarrhea for a relatively prolonged period of time because of hyperperistaltic movement of the intestine, then there is a high chance of weight loss. There is increased appetite though. Okay, increased appetite, but that increased appetite doesn't lead to weight gain. Still the person is losing weight. Very important feature in the history. The person is irritable, okay, with a behavior change. This irritability can be considered as the sympathetic stimulation. Patient is anxious. There is a features of anxiety there. Restlessness is very common. Again, the features of sympathetic stimulation and anxiety. Generalized muscle pain, malaise, stiffness, and weakness of the muscle, especially proximal myopathy. Proximal myopathy can occur in hyperthyroidism. Tremor. This tremor is which type of tremor? We talked about this before. Which type?
Intentional tremor.
Intentional tremor.
Very good. This is known as intentional tremor, and this is a very fine tremor. Sometimes or as a doctor, we fail to diagnose it if we do not pay attention. So, how to demonstrate tremor? You ask the patient to extend the hands in front of you and put a piece of paper, okay, on the dorsal surface of the hand. Now, just look at that paper. The paper is moving slightly because of the tremor. This is an excellent way of diagnosing tremor. Another is chorioathetosis. It's a type of abnormal movement. Breathlessness. Breathlessness can also occur. Uh, the person is having faster breathing. Okay. Palpitation, very, very common symptom. Again, because of the excessive sympathetic stimulation. Heat intolerance, very important symptom. Absolutely important from the history taking point of view. We ask this question all the time. These patients, they also have a bit of sweating, and they cannot tolerate heat even in the winter season. If some other friends, other normal people, they're enjoying the sun, but these people cannot. This is known as heat intolerance. Itching, thirst, vomiting. Okay, these are non-specific feature, but diarrhea is because of hyperperistaltic movement, can be utilized as an important symptom in the diagnosis. Okay, there are certain eye complaints. We'll mainly talk these eye complaints in the sign. There is goiter, means swelling of the thyroid gland. Now, why the swelling of the thyroid gland occurs in this case? Because this is not a case of iodine deficiency. Why? Anybody?
Sir, because of the hyper stimulation, sir, coming from the D3T4 will stimulated by TSH, so the gland will be increased in size.
Good, good. Any other answer? I want to listen one or two. Yes.
The thyroid follicle cell will be stimulated more, sir. Excessive stimulation will occur, sir, to increase the size of thyroid follicle cell.
Hyperfunctioning and hypertrophy of the cells.
Very good.
Excretion of T3T4.
Very good. So all the answers are correct here. All the answers are correct. Nobody is even talking about TSH here. Okay, very good. That's what I want. Now listen properly. Goiter is a swelling of the thyroid gland. Though, okay, there is no concern with iodine deficiency here, but still patient is having enlargement of the thyroid gland, and the mechanism is those antibody. If I talk about Graves' disease, the antibody which are present there are stimulatory type. They stimulate thyroid gland all the time. They are acting like a TSH hormone. So when thyroid gland is stimulated for a prolonged period, naturally it will enlarge in size and it will start to act like a hyperthyroid gland. That is the reason. So some other causes are also there, like multinodular goiter. So in the beginning, multinodular goiter is caused by iodine deficiency. There is no doubt about it. But later on, some of those nodules in multinodular goiter become autonomous. They start to produce more thyroid hormone. Okay, so that is altogether different type of mechanism. Solitary adenoma is a different mechanism. So remember, in Graves' disease, because of constant stimulation by autoantibody, there is goiter. Now, in case of female, there is oligomenorrhea, means decreased menstrual loss. There is loss of libido, and gynecomastia in male. We all know what is gynecomastia. This is enlargement of the breast tissue in male. There is onycholysis, also known as thyroid acropathy. Okay, we'll talk mainly towards the sign. If a child develops hyperthyroidism quite early, they become tall. This is a very true thing because thyroid hormone stimulate, okay, the epiphyseal plate of the cartilage. That's why in hypothyroidism the child is very short in stature, whereas in hyperthyroidism the child becomes tall. And there is excessive sweating. There's no doubt about it. Sweating is a very important feature of hyperthyroid condition. Okay. Now, these eye complaints are only seen in Graves' disease. We'll talk about that. Now, let's go to the sign. Tremor, we can demonstrate that in front of us. That's why it is written as a sign also. The person is hyperkinetic. Okay, this is, you know, a bit of restless person moving around here and there. In no time, the person is reaching different places. Psychosis. Okay, psychosis can occur in case of hyperthyroidism, but not very common point. That's why it is not highlighted. Tachycardia or atrial fibrillation, very common feature in case of hyperthyroidism. This atrial fibrillation usually occur in older patient when they develop hyperthyroidism. Remember this. One of the cause of atrial fibrillation is thyrotoxicosis. Full pulse means bounding pulse. Okay, bounding pulse or high volume pulse, because hyperthyroidism is hyperdynamic circulation, so full pulse is there. When we palpate the periphery, they are warm because of vasodilation. Okay, they feel quite warm. Now, one clinical association I like to highlight immediately here. In case of anxiety, okay, in case of anxiety also, the patient sweat. In hyperthyroidism also, the patient sweat. And many other features are similar. Remember this. How to diagnose these two conditions? Just by examination. Now, in hyperthyroidism, just palpate the hands of the patient. Just do hand shaking of the patient. You will feel the hands very warm along with sweating. But in case of anxiety, because of vasoconstriction, very prominent there, okay, it feels quite cold. So this is a very important point to differentiate between anxiety and hyperthyroidism. Another point is also there. When the patient is sleeping, just take the pulse. In hyperthyroid condition, the pulse is still high. The tachycardia still exists at the time of sleep. Whereas in anxiety, the person is, free of any stress. So the pulse is probably at the normal rate during that time. So these are very essential or important, clues for the diagnosis, clinical diagnosis. Let's move on. There is systolic hypertension. The systolic blood pressure may be higher, and if hyperthyroidism is not treated for a longer time, there may be heart failure. It is one of the cause of cardiac failure because it is a hyperdynamic circulation. Exophthalmos, very common feature of hyperthyroidism, especially Graves' disease. Okay, Graves' disease, that means proptosis. Okay, bulging of the eyeball is called exophthalmos. It's a prominent feature of Graves' disease. There is lead lag and stare look. Lead lag means the upper eyelid is lagging the movement of the eyeball. So what I do there, ask the patient to look towards the ground. Okay, just point a finger and ask the patient to focus on the finger and move that finger towards the ground. Now, during that time, the eyeball is moving towards the ground, but the upper eyelid is lagging behind. That is called lead lag. And a typical stare-like appearance is there. There is swelling of the conjunctiva, which is known as conjunctival edema or chemosis, and it looks quite red also. Later on, there may be ophthalmoplegia. Okay, this is the feature of thyroid ophthalmopathy. There is periorbital edema, edema around the orbit. There is goiter, already talked about, and bruit. What is bruit?
Murmur and periphery.
Murmur like
Murmur and artery.
Good.
Abnormal sound produced in the artery.
Exactly. This is the abnormal sound produced, okay, by the blood flow in the artery. If those arteries are having, excessive blood flow, or if they are narrowed, then bruit is heard. Now, in this case, because of hypervascularity, bruit is heard over the thyroid gland, and the person is having weight loss. On the other hand, there is proximal myopathy. Okay, there may be proximal muscle wasting, onycholysis. Onycholysis means, the person lose the nail, palmar erythema, Graves' dermopathy, which is also known as pretibial, okay, mixed edema. Pretibial mixed edema is another term for dermopathy. And thyroid acropathy. This thyroid acropathy is the combination of clubbing, okay, and swelling of the small joint of the hand and feet. This is known as thyroid acropathy. So many signs and symptoms are present in hyperthyroidism. Some are only seen in Graves' disease, but not in other causes of hyperthyroidism. Now we're talking about the clinical features of hyperthyroidism. Now we'll again repeat some of the important clinical feature which you should remember. Okay, now see there. The eye signs, pretibial mixed edema, and thyroid acropathy occur only in Graves' disease. This is a very important information. So these three things occur only in Graves' disease. The eye sign means thyroid ophthalmopathy, okay, like that exophthalmos, the typical exophthalmos, the lead lag, the stare type of look. All of these are seen in Graves' disease. Pretibial mixed edema is pretibial thickening. There is a deposition of glycosaminoglycan, which are a type of connective tissue substance. They are deposited on the anterior part of the tibia or shin, and that area becomes quite thick. That is known as pretibial mixed edema. Actually, mixed edema is the term for hypothyroidism, because that area just look like, you know, the skin change in hypothyroidism. That's why the term is used there. But this is not a case of hypothyroidism, okay? And thyroid acropathy is the combination of clubbing and swelling of the small joints of hand and feet, especially of the hand. Pretibial mixed edema is an infiltration of on the skin, essentially occurring only with eye disease. So it almost always occur along with thyroid ophthalmopathy. So we need to examine for both. And if they are present, you know, this is highly suggestive of Graves' disease. Thyroid acropathy is very rare and consists of clubbing, swollen finger, and periosteal newborn formation. Because of that, that may be a painful condition because of you know, periosteal newborn formation. It is a bit like a, you know, hypertrophic osteoarthropathy, if you remember. Hypertrophic osteoarthropathy is a grade 4 type of clubbing, but we don't use you know, that grade 4 type of clubbing terms here. We use the term thyroid acropathy, though the findings are a little bit similar. In the elderly person, a frequent presentation is with atrial fibrillation, already talked about, other tachycardia or heart failure, often with few other signs. Thyroid function tests are mandatory in any patient with atrial fibrillation. So see there, so let me underline this important point. Any patient who comes to the hospital with atrial fibrillation, thyroid function test is mandatory, especially if the person is relatively older, because that may be caused by hyperthyroid condition. Children frequently present with excessive weight gain. They present with excessive, height gain rather than weight gain. They lose weight actually, but height, okay, is excessively gained because of the constant stimulation of those epiphyseal plate of cartilage by thyroid hormone. And sometimes they become hyperactive also. So it may be a differential diagnosis of attention deficit hyperactivity disorder, which is a type of psychiatric condition. But this case, this hyperactivity is caused by hyperthyroidism. Let's move on. Now let's see some of the picture here. Now look at this. This is a huge toxic multinodular goiter. Now what is the meaning of toxic here? Yes, what's the meaning of toxic? Anybody?
So they are hyper stimulation. The nodules become hyperactive and secrete thyroid hormones.
Exactly, it's absolutely correct. These nodules are secreting more thyroid hormone. That's why the term toxic is used there. If there is no excessive secretion of thyroid hormone, we simply call them multinodular goiters. Now see this, one of the nodules, or more than one of those nodules may release more thyroid hormone. It is one of the cause of hyperthyroidism. Now another picture is thyroid ophthalmopathy. Thyroid ophthalmopathy. Let's see it carefully. This is called proptosis or exophthalmos. But to see this proptosis correctly, we need to look the patient from the lateral side, okay, not from the anterior side. We have to see the patient from the side. Then the bulging eyeball are very prominently seen. Look at the retraction of the upper eyelid. This is called retraction of upper eyelid. And if I ask the patient to look towards the ground, then the upper eyelid will lag behind the movement of the eyeball. This is called lid lag. These are very, very prominent feature of Graves' disease. Graves' disease. And some of the other female, they present with very red eye. Okay, red eye. This is called chemosis. Chemosis is actually edema of the conjunctiva with redness. And there is a gritty type of sensation on the eye. This is called lid lag. Okay, the upper eyelid is lagging the movement of the eyeball. These are only seen in Graves' disease. Remember that. Now these are the other picture, okay, which are quite prominent. And if a lady comes with this type of feature, you can say from a distance, yes, that's the Graves' disease. It's written everywhere, Graves' disease there. It's periorbital edema and chemosis, swelling of the conjunctiva. Now, one important point, this particular condition can be confused with hypothyroidism also. Hypothyroid female also present like this, but hypothyroidism has so many other clinical features and we can easily diagnose it. This is known as thyroid dermopathy or pretibial, infiltration or pretibial mixed edema. Now see there, this is anterior surface of the tibia. So right there, there is a deposition of those glycosaminoglycan or connective tissue substance, and it is a bit of indurated type of feeling. Indurated type of feeling. Indurated means slightly hard type of feeling. So this is a typical case of thyroid dermopathy. Now here is thyroid acropathy. Here is a clubbing. You can clearly see clubbing here. Okay, and here also the clubbings are shown. And if we take the X-ray, probably some of the phalanges, okay, are having excessive new bone formation because of the periosteal bone formation. So the combination is known as thyroid acropathy. Sometimes they may be painful as well. Now, what are the differential diagnosis of hyperthyroidism? The important one. Let's talk about it. The differentiation of the mild case from anxiety state may be difficult. I already talked about this, okay, but let me repeat again because this is an important one. So anxiety neurosis is one of the important differential diagnoses of hyperthyroidism. The useful positive clinical markers are eye shine, or diffuse goiter, proximal myopathy, and wasting of the body, which are not present in anxiety neurosis. So the different signs of hyperthyroidism will help us. Weight loss despite a normal or increased appetite is a very useful clinical symptom of hyperthyroidism. No doubt about it. We ask this history all the time. And the hyperdynamic circulation with warm periphery seen with hyperthyroidism, which is not seen in a patient with anxiety. In that condition, the hands are quite clammy, okay, and cold. We call them cold and clammy hand because of sympathetic stimulation. The blood vessels are narrow there, okay, along with sweating. So cold and clammy. And one more point you can add there, at the time of sleep, if you take the pulse, okay, the pulse would be decreased in case of anxiety, whereas it is still high in case of hyperthyroidism. And finally, if still your teacher wants some more answer, you can add thyroid function test. Go for thyroid function test, that will clearly give you the diagnosis, which should be normal in case of anxiety neurosis. Now, what are the investigations in case of hyperthyroidism or thyrotoxicosis? Now, this is a very, very important lecture, so please pay attention. Serum TSH is suppressed in hyperthyroid condition. It is less than 0.05 milliunit per liter, except for the very rare instances of TSH hypersecretion. I'm sure almost all students know this point already. Now, the most common type of hyperthyroidism is the primary one, where thyroid gland itself is, overactive. A perfect example is Graves' disease, multinodular goiter, toxic adenoma, and all these things. Whereas the secondary causes of hyperthyroidism is very rare, less than 1%, and that is usually caused by TSH hypersecretion. So the answer is very easy. In case of primary hyperthyroidism, because of excessive release of T4 and T3 from the thyroid gland, they give good negative feedback to the pituitary, so that there is very less amount of TSH coming from there. So if we measure the TSH level, it will be very low. Never forget this. A raised free T4 or T3 confirms the diagnosis of hyperthyroidism. This has to be the first thing I'll do. I have to show this excessive T4, okay, or T3. Now, this is a hyperthyroid state. Is it primary or secondary? For that, I need to do serum TSH analysis. TPO and thyroglobulin antibody are present in most cases of Graves' disease. Now, this is what I was talking in the last class. There are different types of autoantibodies present in thyroid disorder. Now, in Graves' disease also, the blocking type of antibodies may be found, but the role of those blocking antibodies are not much in the pathogenesis of the disease, but they just tell us, yes, this is an autoimmune phenomena or mechanism. That's it. Now see here, thyroid peroxidase, TPO, thyroid peroxidase, okay, antibody, and anti-thyroglobulin antibody, they are mainly blocking type, or they are mainly inhibitory type, okay. So, but still they are present in Graves' disease. TSH receptor antibody are not measured routinely, but are commonly present, and thyroid stimulating immunoglobulin, known as TSI, is present in 80% of the cases. So if they are measured, okay, they are present in 80% of the cases, and they give us the clear-cut diagnosis. Okay, but let me tell you one thing: if a patient presents with typical eye sign, okay, pretibial dermopathy, thyroid acropathy, classical goiter, if she is female, from these clinical clues itself, I know this is a Graves' disease. So I don't need to confirm it by doing TSI. That type of answer we expect from the student. That shows, the confidence level in you. Okay, but other type of answer is also acceptable. You can also clearly say, yes, I want to go for TSI, so that I want to make sure whether it is present in the excessive amount or not in the patient. That is also acceptable, because this is the main immunoglobulin which is causing Graves' disease. Another important investigation.
Sir,
Yes.
sir, I have a question. If a patient of hyperthyroidism
Yeah.
remain untreated, so can it be fatal for the patient?
Of course, because there are so many complications associated with it. Okay, the person may have heart failure later on. Person may have heart failure. The person may have some eye complication because of thyroid ophthalmopathy. Though the
But it
person,
may take years.
yeah, though the person may not die, though the person may not
Oh,
die, but the
yes.
morbidity is quite prolonged, isn't it? Morbidity
Sorry.
is quite prolonged, but the person may die.
Sorry.
You can never say. Remember what we studied in heart failure. the person can die because of cardiac arrhythmia anytime in heart failure or heart disease case, isn't it? So you cannot give a guarantee.
Yes.
Yeah, so that's the point. Okay, so let's move
Okay.
further. So thyroid scan is another type of investigation which shows increased uptake. Now let's see what is that thyroid scan is all about here. See this. Okay, this is called thyroid scan study or radioisotope scan uptake study. This is a normal one. This is how it looks, normal. This is a diffuse uptake of the radioisotope material by both lobe of the thyroid gland. See this? Both lobe, okay, have almost taken the radioisotope material equally, because this is a symmetrical enlargement of the thyroid gland in Graves' disease. Now, in this case, just see here, only few of the nodules have taken the radioisotope material. The other nodules have not taken. So this is toxic multinodular goiter. I can clearly see the different nodules here. And this is toxic adenoma. Only one area have actively uptaken the radioisotope material. So this is one of the very important tests or investigation which is routinely done in the hospital for the diagnosis of hyperthyroidism and to know what is the cause there. So this is iodine 123 or technetium 99M, okay, study. Both of these are radioisotope material. Now see here, so how it looks in case of toxic multinodular goiter. You've already seen that. In the exam, in the Viva exam especially, or in a computer-based exam in your near future, if this type of picture is shown to you and asks you to pick which is the toxic multinodular goiter, it's quite an easy type of question. Look here, there are multiple nodules present here. Okay, so C is the toxic multinodular goiter picture of a thyroid uptake study. This is a single adenoma. Only one part or one nodules have taken the radioisotope material actively. Now this is a pathological specimen of toxic multinodular goiter. The thyroid gland was removed from the patient and it is cut open. Look at these different nodules here, which are separated by the fibrous septa. Okay, this is a typical case of toxic multinodular goiter. We don't know if this toxic or not. To find out whether it is toxic, we need to go for thyroid function test. Now, the last part is the treatment. So please pay attention. It is a very important question from the exam point of view. Three possibilities are available regarding the treatment of thyrotoxicosis, and they are anti-thyroid drugs, radioiodine therapy, and surgery. Anti-thyroid drug, radioiodine therapy, and surgery. And these anti-thyroid drugs are carbimazole, propylthiouracil, and methimazole. So you need to remember this name: carbimazole, methimazole, and propylthiouracil, also known as PTU. PTU, propylthiouracil. Now, this drug inhibit the formation of thyroid hormone. Okay, they inhibit the formation of thyroid hormone, and these carbimazole and methimazole have some important adverse effect. They cause neutropenia, so they are making the patient slightly immunocompromised. So when we use this type of medicine, every 2 weeks we need to check CBC, what is happening to the total WBC count, what is happening with the neutrophil count, just to monitor the adverse effect of carbimazole or methimazole. As many of the manifestations of hyperthyroidism are mediated via the sympathetic system, we have to block, okay, the overactive sympathetic system by beta blocking agent. So which are those beta blockers you want to use here? Yes, which are those drugs?
Non-selective beta. Non-selective beta blocker.
Non-selective, sir.
Exactly.
Pregnenolol, propranolol, labetalol.
Exactly. We want to use, okay, non-selective beta blocker like propranolol. That is the wonderful drug here. We don't want to use only atenolol or metoprolol, those type of drugs, because I want to block the overall generalized sympathetic stimulation. So propranolol is very commonly used along with antithyroid drug in this case. Propranolol also decrease the peripheral conversion of T4 to T3. So that is a additional function. Now, what is the job of radioactive iodine here? It is one of the important treatment done all over the world. So how it works, okay, regarding the management. Radioactive iodine, which is used for the treatment, is 131 iodine, okay, 131 iodine, and the iodine which is used for the investigation purpose is 123 iodine. So just remember that small point here. So this is 131 iodine. So this is given to the patient of all ages, okay, but strictly contraindicated in pregnancy and during breastfeeding, because it is a radioactive substance. We never give radioactive substance during pregnancy and during the lactational period, okay. It's strictly contraindicated. Otherwise it can be used in all other ages. Now this radioactive iodine or 131 iodine is actively uptaken by the thyroid gland because it has iodine content, okay. It accumulates in the thyroid gland and it destroys the thyroid gland by local radiation, although it takes several months to be fully effective. It is an excellent type of therapy, but remember one thing, it permanently destroys the thyroid gland. It permanently destroys the thyroid gland by the radiation effect, and it takes several months to be fully effective. Now, what option we have? We have destroyed the thyroid gland. So after this, we need to replace thyroxine hormone, okay, to the patient. See that hypothyroidism affects the majority of the subject over the following 20 years. So we need to replace them with thyroxine hormone. That is very easy thing to do. It's quite safe also. If I need to choose between antithyroid drug used for 10 to 20 years and use of thyroxine for 10 to 20 years, I'll always go for thyroxine use because it has a very, very minimal side effects profile rather than those antithyroid drugs. Now, there is a slight concern here, okay? Some of the textbook or some of the author, they believe overall cancer incidence and mortality rate, okay, are slightly increased after giving this radioactive iodine therapy because it has got radioactive substance, and we know radioactive substance can cause malignancy. But they have done extensive study all over the world, okay, and they have found the overall cancer incidence and mortality rate are not that increased after the radioactive iodine. So it is commonly used all over the world. Now, what is another therapy left? That is surgery. So we need to remove, okay, some part of the thyroid gland, and that is subtotal thyroidectomy. Subtotal thyroidectomy. We don't go for total thyroidectomy, so then there is no source of the thyroid hormone. Total thyroidectomy is done only probably in malignant cases. This is not a case of malignancy. This is a overactive thyroid gland. So if we remove some part of the thyroid gland, probably patient may benefit from this. So conventional practice is to stop the antithyroid drug about 10 to 14 days prior to surgery and give potassium iodide around 60 milligram 3 times daily, which reduces the vascularity of the gland. So let me explain this point for you because this may be asked sometimes in the exam. This potassium iodide is a drug. If we give prior to surgery, it reduces the vascularity of the gland and it doesn't allow, okay, the release of preformed hormone from the gland. So there are two functions. Doesn't allow the release of preformed hormone from the gland, as well as reduces the vascularity of the gland. So it is advisable to use potassium iodide prior to surgery around 10 to 14 days before. Now, how I know which is the choice of therapy? Now, how many therapy we have discussed? Antithyroid drug with propranolol is one. Radioactive iodine therapy is the second. And subtotal thyroidectomy is the third. So how I know which patient needs which type of therapy? So let's talk about the indication here. The indications for either surgery or a radioactive iodine are patient choice, definitely. Okay, we give all the options to the patient and it's the patient choice, whatever they want to go for. It is their choice and we should respect their choice. Another one, persistent drug side effect, already talked about. Those drugs are not desirable for a long-term use. Poor compliance with drug therapy. Patient is not following and patient is not taking the drug properly. And recurrent hyperthyroidism after drugs. So all of these are important indication for these therapies, either surgery or radioactive iodine. Now, particular indications for surgery include a large goiter which may be compressing the nearby structure, and I should decompress that. Okay, so this is the important indication for surgery, because it takes time for other modality of therapy to act. Now, the last part of this particular lecture is the thyroid crisis or thyroid storm. What do you mean by that? So let's talk about it. This rare condition with a mortality of 10%. So it has a mortality of 10%. That's why it is an important one. Is a rapid deterioration of hyperthyroid condition with hyperpyrexia, severe tachycardia, extreme restlessness, cardiac failure, and liver dysfunction. Now, why is this happening? So let's talk about it. Now, the person is already having hyperthyroidism like Graves' disease. On top of that, if there are certain precipitating factors like stress, infection, or surgery in an unprepared patient, you have not given any potassium iodide before the surgery, and start to do surgery, then what happens? The preformed hormone which are there inside the thyroid glands are released in an excessive amount, and these hormones are responsible for thyroid storm or thyroid crisis. This is the mechanism. Look at the clinical feature here. Hyperpyrexia means high grade temperature. This is quite lethal for the patient. Severe damage to the heart and even liver. So regarding the treatment, it must be urgent, because this is a emergency situation. So we don't have enough time. It must be urgent. Propranolol is given in full dosage here, because a lot of these features are because of sympathetic stimulation. And along with that, we give potassium iodide just to block the release of that excessive thyroid hormone, which are already synthesized. We also give antithyroid drug to block the synthesis of new hormone there. We can give corticosteroid also, but that is a bit controversial. And full supportive measures, give antipyretic drug to decrease the hyperpyrexia. Give a lot of IV fluid to the patient. If patient is very sick, admit the patient in ICU. All these things should be done. Okay, so this is how we control thyroid crisis or thyroid storm. This is a very serious situation in a case of hyperthyroidism.